Welcome to the Deep Dive. We are really thrilled to have you with us today. If you've ever found yourself looking at the massive, sprawling world of healthcare policy and just wondering how anyone decides what is actually right or wrong on a grand scale, you are in the perfect place.
Absolutely. It's a massive topic.
It really is. Let's set the stage right away with an overarching metaphor. Think of public health as upstream engineering. So imagine you have a raging river. Clinical medicine is the heroic, vital act of pulling a drowning person out of that water, drying them off, treating their hypothermia.
Right.
But public health, on the other hand, is trekking 5 miles upstream to build a bridge or maybe a massive dam to stop people from falling into the water in the first place. But here is the catch, and it is a monumental one. If you build that dam, you might save the village below, but you also might completely flood the valley above.
Yeah, you're changing the landscape for everyone.
Exactly. How do you weigh those choices? Whose homes get flooded? Whose lives get saved? That is the essence of what we are unpacking today.
That is the perfect way to frame it. And the purpose of today's deep dive is to serve as your dedicated companion to our primary source material, specifically focusing on the conceptual frameworks of population health. We're looking closely at the ethical principles that govern this field, and then we're going to see how those principles actually hold up in the real world by applying them to population screening.
Right.
We are going to build a conceptual framework together, moving from risk to exposure to outcome to intervention, and finally, system impact. First, we need to establish the moral framework. Then, we will stress test that very framework against one of the most complex, paradox-filled interventions in modern medicine.
Okay, let's unpack this, starting with the very emergence of public health ethics, because the first thing we have to understand is that public health ethics and clinical ethics are completely different animals, right? When we think of medical ethics, most of us picture the Hippocratic Oath. We think of historical figures like Thomas Percival and John Gregory. And in that traditional model, the absolute core focus is on the doctor-patient dyad. Picture a doctor and a patient in an exam room with the door closed.
Just the two of them.
Yeah. It is all about that individual patient's autonomy and well-being. The clinician's duty is singularly focused on the person sitting on the exam table.
Exactly. It's a highly localized, individualistic moral duty. If clinical ethics is like steering a single ship safely to port,
Public health ethics is managing the entire shipping lane.
yes. It is a completely different lens. You are no longer just asking, what is best for this specific patient in front of me? You're asking, what is the fairest and most effective way to distribute our limited resources across millions of people? Public health ethics shifts the focus away from the individual and places it squarely on populations, on equity, efficiency, and social justice.
And looking at the history, that shift didn't happen overnight. We see the rise of bioethics as a distinct field, really taking shape in the 1960s and 70s. This was the era of the Belmont Report, which gave the medical community the big three foundational pillars, which are beneficence, respect for persons, and justice. But what's fascinating is how, in those early days of bioethics, autonomy essentially became the undisputed king of the hill.
Oh, absolutely.
Informed consent became the ultimate moral imperative above almost everything else.
It did, and there was a very good reason for that. Bioethics was reacting to a dark history of paternalism and profound abuse in both clinical practice and research. You had institutions and doctors making decisions for patients, often to their immense detriment, without their knowledge or consent.
Right, like the Tuskegee study.
Exactly. Autonomy absolutely needed to be championed to protect individuals. However, as public health began to define its own ethical space, scholars realized that pure autonomy wasn't enough to solve population-level crises. In 1986, you have Mark Lappe arguing that public health inherently involves compromising individual rights for community interests, provided there is proportionality. But even earlier, in 1976, Dan E. Beauchamp laid down a truly foundational challenge to the prevailing mindset.
That's where the concept of market justice comes into play, right?
Yeah.
Beauchamp really took aim at that idea.
Precisely. He challenged the market justice view, which is essentially the idea that individual choices and free markets alone determine health outcomes. It's that bootstrap mentality. If you are sick, it is purely a result of your individual choices or bad luck. Beauchamp argued that public health actually demands a social justice view. This requires us to look at disability and premature death not as isolated individual failings, but as collective societal problems that require collective systemic action.
So if we adopt that social justice view, it fundamentally changes what we are responsible for. It implies we share commitments to a common life. And from that shift, The core frameworks of public health ethics were truly established. We aren't just checking the box for informed consent anymore.
No, the burden is much higher.
We have to identify overarching health goals for the community. We have to determine the actual measurable effectiveness of our interventions. We have to minimize the burdens we place on people, ensure proportionality, fight for social justice, and maintain absolute procedural fairness. Every time public health steps in, it has to hit these benchmarks.
Which naturally leads to one of the most persistent tensions in the entire field, the balance between health promotion and personal liberty. This is the behavioral spectrum.
Yeah.
The central agonizing dilemma here is just how much should governments be allowed to regulate your personal behavior? To frame this, we often go back to the philosopher John Stuart Mill and his famous harm principle. Historically, restricting a person's liberty is justified if it prevents harm to others. That's why we have laws against driving drunk. But what happens when the government wants to restrict your liberty to prevent harm to yourself?
Right. And this is where we get to a fascinating conceptual map. Back in 1981, Edmund Pellegrino mapped out this spectrum of intervention, showing the varying degrees of how hard a government can push. Let's walk you through it. At the absolute lightest end of the spectrum, you have voluntary health education. This is the government just giving people flyers or friendly advice. Hey, eating vegetables is good for you.
Very low friction, very little infringement on liberty.
Exactly. Then, step 2, you move into opinion manipulation via mass media. Think of those intense, graphic anti-smoking TV commercials that show diseased lungs. They aren't forcing you to stop, but they are aggressively trying to manipulate your desire to smoke. Step 3 is where the economics come in. Tax and insurance incentives, or disincentives. You aren't banning cigarettes, but you are taxing them so heavily that they become economically unappealing. And finally, step 4. At the far end of the spectrum, you have coercive legal prohibitions. Outright banning a substance or a behavior, making it illegal to buy or consume something.
And deciding where to land on that spectrum relies heavily on the principle of proportionality, a concept developed further by scholars like Fadin and Fadin. The golden rule here is that interventions should always favor incentives over disincentives and education over manipulation. You want to use the least restrictive means possible.
Always start at step 1 if you can.
Exactly. If you are going to use restrictive or coercive measures, if you're moving to step 3 or 4 on Pellegrino's spectrum, you carry an incredibly high burden of proof. You have to prove that the public health problem is genuinely severe, you must prove that less restrictive means have completely failed, and you have to prove that your coercive measure will actually be effective. You cannot restrict liberty just to try something out.
So if education fails, at what point does the government actually step in and force a change? We see this debate playing out in real time with chronic diseases. Over the past few decades, we've seen an explosive rise in obesity, type 2 diabetes, and tobacco-related illnesses. These are often framed as lifestyle diseases. And this brings up a really compelling argument from Daniel Wickler. He addresses the idea of corporate influence.
This is a great point.
If massive corporations are spending billions to manipulate individual preferences, say, through aggressive, highly targeted advertising of hyper-processed, addictive foods to children, then government coercion might not actually be an infringement on true autonomy.
Right. It creates a fascinating philosophical divide. On one hand, you have the argument that things like a soda tax or a ban on trans fats are textbook government overreach and paternalism. On the other hand, Wickler's framework argues that the overreach already happened via corporate marketing. In that view, the environment is already profoundly paternalistic towards consuming the unhealthy product, and the government intervention is just leveling the playing field. It is stepping in to protect the individual's ability to make a truly free choice, unburdened by engineered addiction or systemic manipulation. It really depends on where you believe true autonomy starts and ends in a commercialized society.
It completely reframes how you look at the grocery store aisle. But while chronic diseases like obesity test our ethical frameworks slowly over decades, infectious diseases test them instantaneously. If chronic disease is a slow-moving ethical test, infectious disease is a flashbang.
It is the ultimate stress test for public health ethics. When a novel pathogen emerges, the theoretical debates about liberty and proportionality suddenly have immediate life-or-death consequences.
Here's where it gets really interesting. Let's look at how HIV/AIDS acted as a catalyst for modern public health ethics. When HIV emerged in the 1980s, it forced the bioethics community to truly grapple with public health realities on a massive, terrifying scale.
The tension at that time was palpable and immense. On one side of the scale, you had traditional standard public health tools. You had the 1983 CDC guidance attempting to discourage blood donations from at-risk groups to protect the blood supply. You had proposals for mandatory disease reporting to local health departments and aggressive contact tracing to map the spread. These are the tools public health uses to stop an outbreak. But on the other side of the scale, you had massive, entirely legitimate fears regarding civil liberties.
Because the social context of the 1980s was radically different.
Exactly. In the early days of the epidemic, there were no anti-discrimination laws protecting people with HIV. A positive test, or even just being traced as a contact of someone who tested positive, could mean horrific, immediate stigma. It could mean losing your job overnight. It could mean being evicted from your apartment. The ethical debate was agonizing. How do you balance the potential public health benefits of screening and reporting against exposing individuals to catastrophic social ruin, especially when, at that specific time in medical history, there was no guaranteed effective treatment to offer them in return for their cooperation?
It's a harrowing chapter. You are essentially asking a marginalized population to step into the light and risk complete societal destruction for the greater good, while offering them no medical salvation. It deeply refined the ethics of screening and surveillance. You can't just screen people because you have the laboratory technology to do so. You have to comprehensively consider the social and economic devastation a diagnosis might bring in the real world.
And we see similar high-stakes ethical stress tests when we look at pandemic preparedness, like the planning for avian flu or the real-world response to SARS. Only in those scenarios, the primary ethical tension shifted from privacy concerns directly into the brutal realm of resource allocation. Suddenly, we aren't just talking about data, we are talking about who gets the limited supply of antiviral vaccines or who gets the very last mechanical ventilator in the hospital.
Those are the impossible choices.
Yep.
If we have one ventilator and 3 patients in respiratory failure, who gets it? How do we even begin to decide that fairly?
There are several ethical frameworks used to tackle this. Do we prioritize based on the greatest immediate medical need? That sounds fair. But the sickest person might also be the least likely to survive even with the ventilator, meaning the resource is ultimately lost. Or do we use the life stages investment approach proposed by Emanuel and Wertheimer?
How does that one work?
Their arguments suggest prioritizing young adults over infants or the elderly. The rationale is based on societal investment and opportunity. Society has heavily invested in raising a young adult, and that young adult hasn't yet had the opportunity to experience the full stages of life, career, family, aging. An infant hasn't had the investment, and an elderly person has already experienced those life stages. It's controversial, but it's a defined ethical stance.
I can see how that would spark massive debate. What are the other options?
Alternatively, you could prioritize infrastructure maintenance. This means you give the vaccines and ventilators first to frontline healthcare workers, emergency responders, and critical infrastructure personnel. The logic here is instrumental value. You save them so that they can go on to save dozens of others, preventing the entire health system from collapsing.
Every single one of those frameworks leaves someone behind. But what becomes incredibly clear when analyzing these crises is the absolute necessity of procedural justice. Whatever framework a society ultimately chooses to adopt, the process of choosing it must be transparent, reasonable, and accountable. People need to understand why a decision was made. If I don't get the ventilator, I might be angry or devastated, but the system must be able to transparently explain the ethical framework that led to that decision. Legitimacy depends not just on the outcome, but on how the decision was made.
If we connect this to the bigger picture, all of these decisions, from regulating soda to allocating ventilators, are deeply tied to the underlying concept of social justice and health disparities. To truly understand why some populations are so much more vulnerable during a crisis, we have to look at the gradient of health.
Yes, there is a reality in public health that often shocks new medical students or anyone just starting to look at population data. Access to healthcare actually plays a relatively limited role in a population's overall health status. We spend so much time arguing about hospitals and insurance, but the major, overwhelming determinant of health is socioeconomic status, or SES.
It is the single most powerful predictor. To illustrate this comprehensively, we have to look at the famous Whitehall studies conducted by Michael Marmot and his colleagues. This is a watershed moment in public health literature. They studied British civil servants over many years. Now, this is a unique population because everyone in the study had access to the exact same nationalized healthcare system, the NHS. Furthermore, No one in this specific cohort was living in absolute destitute poverty. They all had stable government jobs.
So theoretically, their health outcomes should be relatively similar, right? They all have doctors, they all have a steady paycheck.
That was the assumption. Yet what Marmot found was a stark, undeniable, stepwise gradient. The lower you were on the civil service employment hierarchy, the higher your mortality and morbidity rates. An executive at the top had better health than a middle manager, who had better health than a clerical worker, who had better health than a janitor. And it wasn't a subtle difference. It was a massive disparity in heart disease, chronic illness, and life expectancy.
What's fascinating here is trying to figure out why. If it's not access to a doctor and it's not starving in the streets, what is driving that gradient?
It wasn't just about material deprivation like poor nutrition or living in damp housing, though those play a part. The researchers found it was heavily driven by psychosocial factors. It was about the level of social support a person had, and critically, the amount of control they had over their own workplace and daily life. Yes, an executive has high demands but high control. A clerical worker has high demands but almost zero control over how they do their job. That chronic lack of control, that constant subordinate status, physiologically translates to chronic stress. And chronic, unrelenting stress degrades the human body over time. It wears down the cardiovascular and immune systems.
So if we know this gradient exists, we know it's driven by social hierarchy and control, it leads to the ultimate question of distributive justice. What exactly makes a health inequality unjust? Inequalities exist everywhere. Some people are taller, some people are faster. But when does a health disparity become a moral failing of society? There are three distinct philosophical frameworks used to answer the why behind our policies. Let's walk through them carefully. First, you have strict egalitarianism. This is the idea that everyone should have exactly equal health, period.
On its face, it sounds noble, but the philosophical critique of strict egalitarianism is severe. In practice, achieving absolute equality often leads to what ethicists call leveling down.
Wait, leveling down. So you're saying under that specific framework, if we can't magically cure a disease for the poorest group, the ethical move is to essentially lower the health of everyone else to match. That sounds incredibly dystopian. How does anyone justify that?
It is dystopian, which is why very few people actually advocate for strict egalitarianism in health. If you have a group of sighted people and a group of blind people, and you can't cure the blindness, strict egalitarianism would theoretically demand blinding the sighted people to achieve perfect equality. Because that is ethically repugnant, most public health frameworks reject it and move to more nuanced theories of justice.
That makes perfect sense. So then we move to the second framework, which is prioritarianism. This is heavily influenced by the philosopher John Rawls and his famous difference principle, which was later applied specifically to health by Norman Daniels.
Prioritarianism says that social and economic inequalities are only permitted if they actually work to the benefit of the worst-off members of society.
So it accepts that a gradient will exist. You can have rich executives and lower-paid workers.
Yes, but the system producing that gradient must be lifting the bottom up more than any alternative system would. If allowing executives to make more money drives an economy that builds better public hospitals for the poorest workers, then that inequality is ethically permissible. If the inequality only enriches the top and harms the bottom, it is unjust and must be dismantled. The priority is always the well-being of the least advantaged.
And finally, we have the third framework, sufficientarianism, which is championed by scholars like Madison Powers and Ruth Fadden.
This view takes a slightly different angle. It argues that justice doesn't necessarily demand perfect equality, nor does it rigidly focus only on the bottom. Instead, it demands that every single person reaches a sufficient baseline of health and possesses the core dimensions of well-being necessary for a decent human life.
Like a safety net.
Exactly. We need a floor that no one is allowed to fall beneath. Once everyone is above that defined threshold of sufficiency, once everyone has basic healthcare, clean water, education, and physical security inequalities above that line are considered less morally troubling.
These theories aren't just academic exercises. They are the bedrock of policy. They determine how a health minister decides to spend a billion-dollar budget. But how do we get the data to make these policies in the first place? We have to do research. Which brings us to the profound ethical complexities of public health research. The very first hurdle we have to clear is distinguishing between public health research and public health practice, like routine disease surveillance, because the rules governing them are entirely different.
And that dividing line has historically been very blurry. But clarity came from the pivotal 1999 CDC guidelines. The defining factor comes down to a single word: intent. Why are you collecting the data?
So if a local health department is tracking a sudden outbreak of measles in a local school, they are collecting blood samples, doing contact tracing, interviewing parents. Is that research?
No, that is practice. If the primary intent is to help a local health department do its legally mandated job to protect its specific community from an immediate threat, it is classified as public health practice. It does not require an institutional review board or IRB approval before they act. They just need to go stop the measles. However, if the primary intent of collecting that same data is to produce generalizable knowledge, say you want to publish a paper in a medical journal about the transmission dynamics of this new measles strain to inform global protocols, then it is classified as research.
And if it's research, the ethical oversight dramatically increases.
Exactly. It requires strict regulatory oversight, informed consent protocols, and IRB approval. Now, it gets tricky because practice can eventually yield generalizable insights and research can benefit a local community. But the initial intent of the activity is the dividing line.
But when public health does conduct true population-based research, we run into massive ethical dilemmas that clinical researchers almost never face. Unlike a clinical trial where one single patient sits in a room, reads a 10-page document, and signs a consent form, community-wide interventions often lack the mechanism for individual refusal. Think about it. If researchers are testing the effectiveness of a massive new public health messaging campaign or adding fluoride to a municipal water supply to study dental outcomes, an individual citizen cannot easily opt out. You can't unsee a billboard, and you can't easily avoid the tap water.
This lack of individual consent mechanism is why community consultation is so critical, and the stakes for the community can be incredibly high. It is not just about physical harm, it is about social and cultural harm. This is perfectly illustrated by the Havasupai Tribe v. Arizona Board of Regents case.
This is a landmark case. Let's set the scene for you. You have the Havasupai Tribe living in a remote part of the Grand Canyon. They were experiencing a devastating epidemic of type 2 diabetes, so they partnered with university researchers. Tribe members provided blood samples with the explicit belief and intent that these samples would be used to find a genetic link to their diabetes crisis. They wanted help for their community.
And the researchers did study diabetes. But years later, the tribe discovered that those same blood samples, their DNA, had also been used for entirely different research without their knowledge or specific consent. The samples were used to study schizophrenia, inbreeding, and the evolutionary ancestral origins of the tribe.
And the findings on their ancestral origins directly contradicted the tribe's traditional, deeply held creation narratives about where they came from.
Exactly. What this case raises is the profound question of group harm. The researchers might argue that the samples were de-identified on an individual level, meaning no one knew which specific John Doe had a marker for schizophrenia, but that entirely misses the point of public health ethics. The research stigmatized and harmed the social group as a whole. It undermined their cultural narrative and associated their specific tribal identity with stigmatized mental health conditions without their consent. It proved definitively that population research can inflict deep cultural and social damage, even if no individual physical body is harmed.
It fundamentally changed how researchers view indigenous data sovereignty. And the controversies don't stop with genetics. There are massive domestic and global ethical minefields regarding how we conduct trials in impoverished areas. Let's look domestically at the Baltimore lead abatement trial, specifically the Erica Grimes v. Kennedy Krieger case. This is one of the most hotly debated cases in modern public health.
It is an incredibly difficult case. In Baltimore, there was a severe crisis of lead paint poisoning in children living in low-income inner-city housing. The absolute best intervention, full lead abatement, stripping the house down to the studs, was incredibly expensive. Landlords simply weren't doing it, and the government wasn't funding it on a large enough scale, so children were continuing to be poisoned every day.
So researchers from the Kennedy Krieger Institute wanted to test different, less expensive methods of lead paint abatement. Maybe just scraping the peeling paint and sealing the windows. They knew these cheaper methods weren't perfect. They knew they wouldn't eliminate all the lead. But they wanted to find a partial solution that landlords might actually be able to afford, rather than everyone just throwing their hands up and doing nothing while kids got sick. So they enrolled families in these partially abated homes and tracked the lead levels in the children's blood over time.
And the ethical clash here is intense and deeply polarizing. Was this an honest, pragmatic attempt to find workable, real-world public health solutions in a highly imperfect society where full funding simply didn't exist? Were they trying to make things better, even if they couldn't make them perfect? Or, as the courts and many ethicists argued, was this gross exploitation of a vulnerable, low-income minority population? Were they essentially using impoverished children as biological measuring devices for toxic environments?
Because you would never run a trial comparing a partial solution against a perfect solution in a wealthy neighborhood. The wealthy parents would just demand the perfect solution.
Precisely. It asks a fundamental question. Does accepting and testing a partial solution implicitly condone and normalize the underlying social injustice that created the problem in the first place? If you accept that poor kids only get partial abatement, are you cementing a two-tier health system?
And we see that exact same tension globally. This brings us to the famous CIOMS placebo controversy regarding HIV vertical transmission trials. This is the debate over how to stop mothers from passing HIV to their babies during childbirth.
In the 1990s, we had a highly effective treatment in wealthy countries, the ACTG 076 regimen. It drastically reduced the rate of HIV transmission from mother to child. However, it was incredibly expensive and required complex intravenous delivery. It was completely unfeasible for use in resource-poor settings like sub-Saharan Africa. So researchers wanted to test shorter, much cheaper oral regimens of antiretroviral drugs in these low-income countries.
But the ethical explosion happened because of how they designed the trial. They tested these new, affordable drugs against placebos. They gave some mothers the cheap drug and some mothers a sugar pill and tracked how many babies contracted HIV. And the global bioethics community erupted because highly expensive, highly effective regimens already existed in the West.
Again, we are looking at how our sources present this profound debate. One side argued fiercely that it was a horrific violation of universal human rights and the Declaration of Helsinki to withhold a known life-saving treatment from a patient just because of where they lived. If a cure exists anywhere in the world, you cannot use a placebo. The other side, however, argued from a strict utilitarian public health perspective. They argued that the expensive Western regimen was not the standard of care in the local setting because no one there could access it anyway. They argued that testing against a placebo was the only scientifically rigorous way to rapidly prove that a cheap intervention actually worked. And if they could prove it worked, they could deploy it and save millions of lives that would otherwise be lost while waiting for the perfect, expensive cure.
It is the ultimate clash between universal clinical ethics and pragmatic public health utilitarianism.
Yeah.
And the debate over who owns data and biological materials is only expanding. Think about biobanks and genetics in cases like Moore v. Regents of the University of California. John Moore had a rare leukemia. His doctors removed his spleen, and without his knowledge, used his unique cells to create a patented, incredibly lucrative cell line. The courts ultimately ruled he did not have property rights to his discarded cells.
Which set a massive precedent for public health research. Today, we are shifting away from specific, one-time consent for a single study and moving toward blanket consent, where you give a blood sample to a biobank, and your genetic material might be used for global data sharing across thousands of studies forever. As genomic data explodes and AI learns to mine that data, questions of privacy, ownership, and group harm are only getting more complex.
Okay, we have built a massive, sturdy, ethical framework. We've talked about social justice, proportionality, the difference between individuals and populations, the limits of state power, and the ethical minefields of research. Now it is time to take all of that theory, all of those high-minded concepts, and stress test them against one specific, incredibly complex public health tool. We are transitioning to the practical application of population screening.
Think back to our conceptual framework. Risk leads to exposure, which leads to an outcome, which prompts an intervention, which causes a system impact. Screening is a fascinating intervention. To use an analogy, population screening is like setting up a massive early warning radar system across an entire country. It scans the horizon looking for threats before they strike. On its face, it sounds inherently purely beneficial. Catch the bad thing early, right?
Right. Catch it early, save a life. It is the ultimate public health slogan. It sounds like common sense.
Yeah.
But here is the massive ethical difference that changes everything. In clinical medicine, a sick patient comes to a doctor asking for help. They have a lump, or a cough, or pain. They are initiating the relationship because they are suffering. In population screening, the dynamic is entirely reversed. The healthcare system goes out into the world, knocks on the door, and offers a medical intervention to a presumed healthy person.
That reversal is everything. By offering that test to a healthy person, The state or the healthcare system is making an implicit promise. They're saying, if you take this test, it will provide a net benefit to your life. Because we're intervening on healthy people who didn't ask for our help, the ethical burden, specifically the principles of non-maleficence, which means do no harm, and proportionality is exponentially higher.
We have to clearly differentiate this because the terminology gets confusing. Population screening is the systematic, organized offer of a test to an entire defined population. For example, sending a letter to every single woman over the age of 50 in a country, inviting them for a mammogram. This is entirely different from opportunistic case finding or routine testing.
Yes. Opportunistic testing is what happens when a doctor decides to check a diabetic patient's eyes during a routine visit because they are already in the clinic, they already have a known disease, and the doctor is managing a known risk factor. The ethical bar for opportunistic testing is much lower. But for population screening, the bar is astronomically high.
So if we are going to roll out this massive national radar system and invite millions of healthy people to be scanned, how do we know it's actually doing more good than harm? The absolute gold standard for evaluating this is the Wilson and Younger criteria, first published in 1968 and later refined by bodies like the UK National Screening Committee.
The prerequisites laid out in these criteria are incredibly rigorous. You cannot just screen for a disease simply because you invented a test for it. First, the condition has to be an important public health problem. We must thoroughly understand its natural history. How does it progress from latent to symptomatic? We need a simple, safe, validated test that the public will actually accept.
And crucially, this is the big one that stops many screening programs in their tracks. An effective treatment must exist.
Absolutely. If you can't treat the disease, you have no ethical business screening for it on a population level. All you are doing is taking a healthy person and turning them into an anxious, doomed patient earlier than necessary.
To understand why these criteria are so strict, we have to clarify the mathematical metrics of the tests themselves. Sensitivity versus specificity, because no test is perfect.
Let's break that down. Sensitivity is the test's ability to correctly identify those with disease. A highly sensitive test means you don't want to miss any true positives. Specificity is the test's ability to correctly identify those without the disease. A highly specific test means you are avoiding false positives.
And there is a massive clinical misconception out there. Clinicians, because they deal with sick patients, often think sensitivity is king. We can't miss a single case. We need 99% sensitivity. But in the world of public health screening, where you are testing millions of perfectly healthy people, the math changes drastically.
If we connect this to the bigger picture, most diseases we screen for have a prevalence of less than 1% in the general population. The vast, vast majority of people you test do not have the disease. When prevalence is that low, specificity becomes arguably much more critical than sensitivity.
Why is that?
Because if your test has even a slightly low specificity, say, it gives a false positive 5% of the time and you test 1 million healthy people, you are going to generate 50,000 false positives. You will be drowning in healthy people who tested positive. This destroys public trust, it causes immense psychological harm, and it completely overgirds the healthcare system with unnecessary, expensive, and sometimes invasive follow-up tests.
Let's make this concrete with a fantastic example. We need to talk about positive predictive value, or PPV. This is the metric that actually matters to the patient. PPV asks, if my test comes back positive, what are the actual odds that I have the disease? The math here is heavily dependent on prevalence. Imagine you were screening for thalassemia, a genetic blood disorder. You are in a high-prevalence hospital in London, serving a community where the genetic trait is common. You use a specific blood metric cutoff. Because the disease is common in that specific building, your PPV is 77.4%. That means if a patient tests positive, there's a 77% chance they actually have the disease. That's a solid, highly useful test.
But here's the critical part. If you take that exact same test, the exact same machine, with the exact same inherent sensitivity and specificity, and you move it to a rural clinic in a low prevalence area where the disease is incredibly rare, the PPV drops to 1.3%.
Let that sink in. A PPV of 1.3%. That means that out of every 100 people in that rural clinic who get a terrifying phone call saying their test was positive, 98 or 99 of them are completely healthy. They do not have the disease. They've just been told they might have a serious genetic condition entirely because the test was deployed in the wrong population.
This perfectly illustrates the harms of screening. The harms are real and they are severe. We aren't just talking about the financial cost of running a second blood test. We are talking about severe psychological anxiety. People lose sleep, their blood pressure spikes, they write their wills. We are talking about overdiagnosis, which is finding microscopic abnormalities that never would have grown or caused the patient harm in their natural lifetime. And that leads to overtreatment, subjecting healthy people to biopsies, surgeries, or toxic medications they fundamentally didn't need.
Which naturally leads us to the economics, opportunity costs, and organization of screening programs. Because scaling this up is mind-boggling. It's easy to look at a simple blood test or a swab and think, well, that's cheap, it's just $10. Why not test everyone? But screening is not just a cheap test. It is an incredibly expensive, massive industrial undertaking.
And in public health economics, we always have to think about opportunity costs. We usually measure these in quality-adjusted life years, or QALYs, and disability-adjusted life years, or DALYs. The hard truth of public administration is that budgets are finite. Every single dollar the government spends on hunting for a rare disease in millions of healthy people is a dollar that is not being spent on treating sick patients waiting in the ER, or building new schools, or fixing roads.
Furthermore, pre-assessments for these programs often completely underestimate the hidden costs. The initial budget might just calculate the cost of the plastic test kit, but the hidden costs are astronomical.
Absolutely. It's not just the cost of the physical test. It's the cost of building massive, secure IT systems to hold the data. It's the cost of paying quality assurance boards to monitor the labs. It's the cost of the anxious patient going to visit their general practitioner 3 times because of false positive, taking up appointment slots that sick people need.
And sometimes, the economic models are just flawed from the start because they rely on static data in a dynamic world. Look at the abdominal aortic aneurysm, or AAA, screening programs. The initial models to justify the massive cost of ultrasound screening older men were built using older data from a time when smoking rates were much, much higher. AAA is heavily linked to smoking. As public health campaigns successfully drove smoking rates down over the decades, the actual prevalence of AAA plummeted, meaning the entire cost-effectiveness model of the screening program was built on an outdated, crumbling foundation.
This highlights why systems thinking is non-negotiable in public health. A test is not a program. Handing out 1 million test kits is completely useless if you don't have the robust infrastructure behind it. You need call-recall systems to track who has been invited, who hasn't responded, who needs a reminder, and critically, who needs follow-up after a positive result. You need fail-safes.
The UK cervical screening program is often held up as a gold standard of this system's thinking.
It is. They have interlocking fail-safes built into every level. The call-recall center tracks the invitations, the general practice clinic tracks the appointments, the cytology lab tracks the sample quality, and the colposcopy clinic tracks the surgical follow-up. If any one of those steps drops the ball, if a lab loses a slide or a patient misses an appointment, another step in the system catches it and flags it. Without that integrated system, screening is not just wasteful, it is actively dangerous because you give people a false sense of security while losing them to follow up.
So if screening is so fraught with complex math, false positives, massive hidden costs, and the risk of overdiagnosis, why does the public absolutely love it? Politicians campaign on expanding screening. Charities raise millions for it. This brings us to a fascinating psychological concept: the popularity paradox and governance.
It's an incredibly powerful phenomenon documented by researchers Muir Gray and Angela Raffel. They call it the popularity paradox. It goes like this. The greater the harm a screening program causes through overdiagnosis and overtreatment, the more popular the program actually becomes in the public eye.
That seems entirely backward. Why would causing harm make it popular?
Because of how humans perceive salvation. Think about it. If a screening program is highly inaccurate and has massive overdiagnosis, it will flag thousands of perfectly healthy people with abnormalities. Those people are then subjected to biopsies or surgeries or radiation for tiny, slow-growing anomalies that never would have hurt them. But the patient doesn't know that. They survived the surgery, and they now deeply, truly believe that the screening program saved their life. They become passionate vocal advocates for a test that actually harmed them.
It's a bit like giving someone a sugar pill, making them severely nauseous with an unnecessary antidote, and having them thank you profusely for curing a deadly headache they never actually had. But on a massive societal scale, it is counterintuitive, but it explains so much about public health politics. It explains why it is almost impossible to stop a screening program once it is started. You have immense public demand from survivors, you have politicians who feel the intense need to do something to show they care about health, and you have massive commercial interests selling the testing equipment. It is an unstoppable train of good intentions and bad math.
Which is why governance is so critical. Stopping a program requires immense political courage. But there is a rare, famous victory of evidence over momentum, the Japanese child neuroblastoma screening program. Japan started screening infants for neuroblastoma, a type of nerve tumor, in 1985. It was hugely popular. Parents loved it. But by the 1990s, rigorous international data began to show a dark reality. The screening wasn't reducing mortality from the aggressive tumors. It was just catching hundreds of slow-growing, harmless tumors that would have naturally regressed on their own. It was subjecting healthy infants to unnecessary chemotherapy and surgery.
So what do they do?
Because Japan had a strong national-level governance structure for screening, and because the medical community effectively communicated the hard evidence to the public, the government was able to officially halt the national program in 2004. This illustrates exactly why governance decisions about screening must be made at a high national level. They must be isolated from local financial incentives or specialized clinical biases, like a hospital that wants to use its shiny new MRI machine that want to push tests regardless of population-level evidence.
All right, let's bring it all home and look at how this plays out across an entire human life. We're going to do a conceptual analysis of specific programs across the life course, applying everything we've just learned about ethics, math, and systems. Let's start at the very beginning of life. Antenatal and newborn screening.
This is a highly sensitive area. Currently, we successfully screen newborns for conditions like Down syndrome and biochemical conditions like phenylketonuria or PKU. When we catch PKU early, we can change the infant's diet and prevent severe cognitive impairment. That is a massive public health victory. But history gives us a stark warning about the ethics of genetic screening. Look at the 1970 U.S. Sickle Cell Act.
This is a textbook example of how a good intention can cause immense harm if you ignore the system impact.
Exactly. The government rolled out massive testing for sickle cell disease in the African American community. But they did it without adequate public education, and crucially, they failed to help the public differentiate between actually having the disease and merely being a genetic carrier of the trait.
So you had people who were perfectly healthy who just carried a recessive gene being told they had sickle cell.
Yes, and the fallout was disastrous. Healthy carriers faced severe social stigma. They were denied life insurance. They faced employment discrimination, including being barred from the armed forces or commercial airlines, all based on a fundamental misunderstanding of the test results. It shows the extreme danger of genetic exceptionalism and poor public health planning.
Let's move to cancer in adults, which is where the debate is absolutely the fiercest today. Breast cancer screening via mammography. The debate here centers around two massive statistical illusions that confuse the public and politicians alike: length time bias and lead time bias. Let's break these down carefully.
Let's start with length time bias. Think of a fishing net. If you pull a net through the water periodically, you are much more likely to catch the slow, lazy fish than the fast, aggressive ones. Cancer is similar. Some tumors are incredibly aggressive and fast-growing. They pop up and become symptomatic in the months between your annual screening appointments. Other tumors are very slow-growing and indolent. Because they sit there for years, they're the ones most likely to be caught by a routine, periodic screen.
So the screening program looks highly successful because the people whose cancers are caught by screening survive a long time. But they survive a long time because their specific type of cancer was already slow and less aggressive. The screening didn't necessarily change the biology, it just disproportionately captured the easier cases.
Precisely. That is length time bias. Now, lead time bias is even more deceptive. Imagine a foot race. Two runners are going to run the exact same distance at the exact same speed and finish at the exact same moment. But for runner A, you start the stopwatch when they are halfway down the track. For runner B, you start the stopwatch the moment they leave the starting block. Runner B's recorded time will be much longer, but they didn't actually run any slower or finish any later.
How does that apply to cancer?
Lead time bias occurs when a screening test simply moves the date of diagnosis earlier in a person's life without actually extending their ultimate lifespan. Imagine a woman who is destined to die of breast cancer at age 70. Without screening, she feels a lump at age 67, is diagnosed, and dies at 70. She lived 3 years as a cancer patient. With screening, the tumor is caught on a mammogram at age 60. She still dies at age 70. She didn't live a single day longer. But in the statistics, she survived 10 years after diagnosis instead of 3. The program claims a massive increase in survival rates, but all it actually did was force her to spend 7 more years of her life living with the anxiety and toxic treatments of being a cancer patient.
Because of these biases, measuring the true effectiveness of screening is incredibly difficult. We use a metric called the number needed to screen, or NNT, It tells us how much effort's required to achieve one positive outcome. And for breast cancer, the NNT is staggering. Estimates suggest you have to screen roughly 2,451 women over 5 years just to prevent one single death from breast cancer. That is a massive investment of systemic resources, and it guarantees a huge number of false positives and overdiagnoses for that single life saved.
Cervical cancer screening is similarly resource-intensive. Historically, you have to screen about 1,000 women regularly for 35 years to prevent one death. However, this is a beautiful example of a system evolving. We're transitioning away from the old cytology smear tests to much more accurate HPV DNA testing. And even more profoundly, with the HPV vaccine rolling out globally to young people, the future need for this massive continuous screening infrastructure is going to change dramatically as the underlying prevalence of the virus plummets.
Colorectal screening using fecal occult blood testing has been proven quite effective and meets the Wilson and Younger criteria well. But prostate cancer, using the PSA blood test, is highly emotive and deeply problematic.
Our sources are very clear on prostate screening. Currently, there is no public health case for systematically screening well individuals. The reality of prostate cancer is that many more men die with it than of it. It is often incredibly slow-growing. A massive national PSA screening program would lead to catastrophic levels of overdiagnosis. This leads to treatments like prostatectomies or radiation that can cause severe, permanent quality of life issues, such as incontinence or impotence, for a cancer that likely never would have become symptomatic in the man's lifetime.
Then we look at cardiovascular and metabolic diseases. We're seeing a strategic shift away from hunting for specific diseases and moving toward whole population risk reduction. Think of things like the NHS health checks in the UK, which look at overall lifestyle factors, blood pressure, cholesterol, BMI, to manage holistic risk rather than diagnosing a specific latent disease. We do have effective screening for complications, like diabetic retinopathy eye exams, but as we discussed, those require intense, flawless quality control systems to actually work.
Finally, as we look at the elderly population, the entire focus of screening shifts. We move away from large-scale, population-wide disease screening. Searching for slow-growing cancers in an 85-year-old often violates the principle of non-maleficence. Instead, we focus heavily on opportunistic case-finding. When an elderly patient interacts with the healthcare system, we use that opportunity to look for immediate, highly actionable quality-of-life issues. Assessing their risk of falls, checking for social isolation, testing for sensory loss like hearing or vision, and conducting thorough medication reviews to prevent polypharmacy adverse events.
What an incredible journey. We have covered an immense amount of ground. Let's summarize the core of this deep dive. We've traced the path from the abstract, foundational ethical theories of social justice, autonomy, and proportionality, all the way down to the gritty mathematical reality of lead time bias, predictive values, and the economics of population screening.
We have. And the crucial takeaway for anyone working in or studying public health is to internalize the core framework. Risk leads to exposure, leading to an outcome requiring an intervention, resulting in a system impact. Every single public health decision, whether it's a local quarantine mandate, a national tax on sugary drinks, or rolling out a multi-billion-dollar breast screening program, requires a rock-solid, evidence-based justification. Why? Because by its very nature, public health inherently impacts the liberty, the resources, and the well-being of the collective. You cannot act without justification.
And here is a final provocative thought for you to consider as we wrap up today's session. As genomic sequencing gets cheaper by the minute, and as artificial intelligence predictive models become completely ubiquitous in healthcare, the very line between being a presumed healthy person and a pre-symptomatic patient is going to vanish entirely. If in 10 years we can screen your entire genome at birth and predict with 90% accuracy every potential future risk you might face over your lifespan, the ethical question will no longer be, can we afford to screen? The real profound ethical question is going to be, do you have the right not to know? If the data is there, can you choose ignorance? It is a massive philosophical hurdle, and it is something for you to mull over as you continue your studies. All right, before we officially sign off, we're going to lock in this knowledge. Let's do a quick knowledge check with some rapid single best answer recall prompts based directly on the concepts we covered. I will read the question, take a brief pause to let you think of the answer, and then provide the solution and the reference area. Ready? Question 1. According to the CDC's 1999 guidelines, what is the primary factor that distinguishes public health research from routine public health practice? Think about that for a second.
The answer is the intent of the activity. If the primary intent is to produce generalizable knowledge, it is classified as research. You can review this in the ethical principles section regarding research.
Question 2. Which ethical theory of distributive justice asserts that social and economic inequalities are only permitted if they result in compensating benefits for the least advantaged members of society? I'll give you a second.
The answer is prioritarianism, specifically drawing from John Rawls' difference principle. That's also in the ethical principles section under social justice.
Question 3. In the context of evaluating a screening program, what do we call an apparent increase in survival time that occurs simply because the disease was detected earlier without actually changing the time of the patient's ultimate death? Take a moment.
The answer is lead time bias. You'll find this detailed in the population screening mechanics section.
Question 4. If a disease has a very low prevalence in a population, say less than 1%, what mathematical impact does this low prevalence have on the predictive values of a screening test, assuming the test's sensitivity and specificity remain constant? Think about that.
The answer is it significantly lowers the positive predictive value, or PPV. This leads to a high ratio of false positives to true positives, exactly like the thalassemia clinic example. Review the metrics section of population screening.
Question 5. What is the psychological phenomenon described by researchers Raffel and Gray, where the greater the harm caused by overdiagnosis and overtreatment in a screening program, the more people falsely believe the program saved their life? Take a second.
The answer is the popularity paradox. This is covered in the governance and popularity section of screening.
Question 6. The 1970 U.S. Sickle Cell Act is widely cited as an example of a screening program that caused profound social harm. What was the primary public health failure of this specific program? I'll give you a moment.
The answer is it was introduced without adequate public education, leading to severe stigma and employment discrimination against healthy individuals who were merely genetic carriers of the trait, rather than having the disease itself. Reference the life course screening section.
Here are the details of this episode.
Ethical Principles and Ethical Issues in Public Health, byline, Balancing Liberty and Life, the Moral Compass of Population Health. Episode description. Public health routinely operates at the intersection of individual rights and collective benefit. Vaccination mandates, quarantine orders, food regulation, taxation of harmful products all raise ethical questions. In this chapter, we examine how public health ethics differs from traditional medical ethics. While clinical ethics centers on the doctor-patient relationship and autonomy, public health ethics focuses on populations, equity, and social justice. We explore foundational principles: beneficence, non-maleficence, justice, respect for persons, proportionality, least restrictive means, and procedural fairness. Public health interventions often affect individuals who have not consented, making justification, transparency, and evidence essential. The chapter addresses recurring dilemmas. When is it legitimate to limit liberty? How should scarce resources be allocated? What obligations exist to protect vulnerable populations? How should competing goods be balanced? The chapter addresses recurring dilemmas. Importantly, public health ethics emphasizes fairness in both outcomes and processes. Legitimacy depends not only on results, but on how decisions are made. The chapter addresses recurring dilemmas. Ethics in public health is not an abstract add-on. It is central to maintaining public trust and social cohesion. The chapter addresses recurring dilemmas. Key takeaways. The chapter addresses recurring dilemmas. Public health ethics differs from clinical ethics in scope and focus. The chapter addresses recurring dilemmas. Interventions affecting liberty require strong justification. The chapter addresses recurring dilemmas. Proportionality and least restrictive means are guiding principles. The chapter addresses recurring dilemmas. Equity and social justice are core public health values. The chapter addresses recurring dilemmas. Transparency strengthens legitimacy. The chapter addresses recurring dilemmas. Resource allocation must balance efficiency and fairness. The chapter addresses recurring dilemmas. Public engagement enhances ethical decision-making. The chapter addresses recurring dilemmas. Ethical reasoning is essential in crisis response.